Some of you may wonder why an environmental chemist might have something to say about COVID in Bangladesh. And what I'm going to tell you about is really a spin-off from an involvement by public health scientists at the Mailman School of Public Health and geoscientists at Lamont for the past 20 years. This is a new project, a separate project that's actually led by my colleague, collaborator, economist Prabhat Banwal at Michigan State University. And the field work essentially has been conducted by Innovations for Poverty Action Bangladesh. And they've done a fantastic job, I think you'll see. The project is actually related to arsenic in tube well water. In January, and it is about mitigation, how to reduce people's exposure to high arsenic in well water. And the project funded by the National Science Foundation relied very much on social interactions, people sharing wells. And so for obvious reasons, when news of the pandemic spread, we had to stop this at the end of January, a year ago. But fortunately, before that, we had conducted a complete census of a large population of over 70,000 distributed across 132 villages. And IPA had the good idea of also recording 2 phone numbers from each household. The vast majority of households have cell phone numbers, often smartphones in Bangladesh today. And so what I'm going to tell you about builds on this information. Some of you may have seen these 2 interesting articles that came out recently. One of them in the March 1st issue of the New Yorker, and another one more recently in the New York Times, pointing out a puzzling finding, which is that the death rates in Western countries, a number of Western countries, the US, Western Europe, is at least 1 to 2 orders of magnitude higher in these countries compared to, for instance, India or Bangladesh. And so the big question is why that is. Could it be undercounting? Could it be under other factors? And the issue that we are addressing is the counting in this particular study. And this is an interim report. There still is some additional analysis that will be required, but I hope that this will give you an initial idea of where we're heading. And our findings are essentially consistent with these 2 articles. So if you go to the WHO dashboard, an official 8,500 deaths have been reported for Bangladesh. And PCR-based testing has added up to over 500,000 confirmed cases throughout the country. How does that compare to mortality expected from the population? For that, you can simply go to the World Bank data set and multiply the total mortality of Bangladesh, which is on the order of 5.5 per 1,000, by the population of 163 million. And so you come up with 900,000 annual deaths. And so the 8,500 deaths account for a bit less than 1% of total mortality in the country. And so that number obviously would be rather difficult to detect, given that there must be changes from year to year. How does this compare to similar numbers for the US? Well, the US has, of course, a considerably older population, and the impact of COVID has been dramatic. I find this a particular revealing plot every time because it compares mortality on a weekly basis for several years, 5 years before 2020. And when you integrate that, the difference in mortality, the increase in mortality between 2020 and 2013 to 19 average is an increase in 19%. And so our sort of goal was to find out whether we could provide any observations that would test whether the mortality is anywhere close to that figure in a country like Bangladesh. So one thing that is important to remember is that deaths are very incompletely recorded in Bangladesh. This is a piece that came out not too long ago in the Bulletin of the World Health Organization, where an attempt was started to increase the vital, collection of vital statistic data. And early on in the paper, the point is made that on the order of 30% only of deaths in Bangladesh are registered within 45 days, and that was out of 2016. So relying on this type of information, especially if you take into account the delay, makes it very difficult to track mortality trends as they are in other parts of the world. I mentioned the 500,000 cases over in the past year. This is a map that I put together based on of reported cases, PCR-based tests, reported by the government's office. And what you see here are the various districts of Bangladesh, with obviously the largest number of cases around the capital, and but also thousands of cases reported in other areas of the country, including the area where we started our study, our arsenic-related study, back in January 2020. And the villages that I'm going to talk about are these little black dots here within the rectangle. And you see that those areas here are in the category where thousands of cases have been reported. Zooming in, and just to give you a sense of scale, Dhaka, the capital, is here on the left here. And you can see that our villages are located between, say, 50 to 100 kilometers from Dhaka in the northeasterly direction. They are located on both the banks of the Meghna River, which is one of the three main rivers flowing through Bangladesh. And those villages, it may be worth mentioning, they were selected essentially because they are of interest from an arsenic mitigation point of view. Essentially, on average, half the wells in these villages have too much arsenic and half of them don't. And so we picked that area for that reason. So it is a sample of the country, but there's no obvious reason to think that that it would be unrepresentative of Bangladesh more widely. The little circles essentially give you two pieces of information. So there are 132 of them, as I pointed out. In some cases, they are complete villages, and we'll zoom in on a couple in a second. And in some other cases, they are actually portions of villages, typically fairly natural boundaries, north of a certain road or something like that. And the reason we didn't cover the entire village is essentially that we didn't have the resources to do so for this experiment, and we also didn't need to do it for this experiment, which, by the way, is a randomized controlled trial that has recently been relaunched. So the size of the circle, oh, I'm missing something. So the smaller side on the legend here corresponds to a population of 250, and the larger one to 1,000. The average population by each of these units, so village or subunits of villages, is 550. And the pies indicate the proportion of the households we were able to reach after January 2020. So the whole study was launched with an in-person survey of all the households in these villages or portions of villages. 16,000 households, a population of almost 73,000. And then was followed by 2 rounds of phone calls. A first round of phone call conducted mostly in May of 2020. And the information that was recorded was deaths, not only in 2020 as of that time, but also in 2019. And then another round of phone calls that was conducted mostly in November, where again, death information was recorded. Now, one thing I want to point out is that we learned from Joel Cohen, who is at the Earth Institute and at Rockefeller University, we learned that it's not in conflict areas, for instance, when there's an attempt to gather this type of information, you don't ask a household, well, did anyone die in your household? You could imagine why that would not be a good approach. And people report it. And so the way it was done is that essentially this was a repeated census. So a first census was obtained in January, and then the phone call, the first one and the second one, essentially people were asked, so please list who is in your household. And a household in this study was defined as relatives who share a kitchen, for simplicity. And so essentially these households were checked when they were already recorded. And if there was a discrepancy, and it could be either fewer or more household members, this was recorded. And then the reason for the discrepancy was investigated. I think that's an important piece of information. It turns out that we were able to reach over 90% of the households in May 1st. And then only 72% on the second call. We're not quite sure why there was such a big drop off. We've heard that people were tired of these phone calls. You know, they were half an hour long because there were a number of other questions related to the arsenic study that we were asking. Maybe in hindsight, we should have done fewer of that. What we did learn is that there was also considerable in-migration. So there was a partial lockdown at least, and a lot of migration to the countryside. And so our original population of 52,000 actually grew up to almost 60,000. And then some of these people have left since. But I will refer everything to this original 52,000, otherwise it gets a bit too complicated. So yes, here actually the legend has these numbers, and what I pointed out, so 72% of responses on average, but you can see that it also varies from one village to the other. This village here, we had clearly over 90% of people responding, and others is closer to 50%. So it does vary from one village to the other, and we don't quite know yet why. So let's focus in on two examples here in the rectangles on the two sides of the Meghna River, one with close to total coverage and one that is less than 2/3 coverage here. Zooming in with the river in between, and to give you an idea of the landscape as a satellite image here. And I want to describe that for you. What you see, the little rectangles that you see are open rice fields. And they are separated by these features that look like riverbanks, and that's often why they are, because that's a slightly raised area compared to the river, and so it protects you from the seasonal flooding. What you see is sort of more granular structure, texture. These are trees, it's tree covered. So where people live, where people have their houses, is also where the trees grow. And so what you see is these features are villages or a combination of several villages. So we're going to zoom into this one to the north and then to the second one to the south. And I have here a scale bar showing you the 1 kilometer to give you a sense. So here's the first village, Pashimbaria, with a total population in that portion of the village inventoried in January 2020 of 733, and 88% of those were reached both in the first survey and in the second survey. And those two surveys reported a combination of 4 deaths in 2019 and 4,000 in 2020. The households that did respond are shown in black, and the white ones, which you can see are pretty uniformly distributed through the villages, are shown in white. So let's look at the other illustration here. So here we have a lower response rate in Santipur, slightly lower population, 62% responding. But again, the white and the black dots are pretty widely distributed throughout the village. In this case, even though it's only slightly smaller, only 2 deaths were recorded in 2019 and none in 2020. So obviously looking at individual villages is not going to be so useful. You want to integrate this for the overall set of villages, and that's what we're going to do from now on. Zooming back out and looking at these 132 locations, here the circles show the location of these units, population units, and in the circle is a number of deaths recorded for each of those in 2019. And you can see that these numbers vary from 0 to a maximum of 8 in some of the villages, and they sum up to 353 deaths for 2019, based on this repeated census approach that I described earlier. In 2020. So this survey, the second wave, was started on October 27. And so we obviously were recording deaths before that. 287 deaths were recorded. There's no very strong seasonal pattern that we can see so far for 2019 or 2020. And just for simplicity, what I'm going to do is I'm going to prorate that number of 287 and multiply it by the number of days in 2020, divide by the 301st day, which corresponds to October 27. And so we come up with a total number of 349. So the crux of the story really is the comparison of this 353 for this population and 349 in 2020. So what does this tell us? Well, without going through any calculation, it's obvious that there was, if these records are accurate, there was no large increase in mortality between the 2 years, if anything, a tiny decrease. So let's get an idea of what the errors might be on this. The next step for us is going to work with Yuling Yao, who is a student of Andrew Gelman in statistics, and we're going to do a more serious job controlling for various factors. But I think this already will give you an idea of what we can say with some confidence. So if you convert these, if you divide the 353 deaths by the total population of 52,000, you come up with a crude mortality rate of 6.8 per 1,000. And the 349, obviously, is just a tiny bit smaller at 6.7. Now, remember, I mentioned that for the country overall, it's 5,000. But several papers have been published showing that rural mortality in Bangladesh is actually higher than urban mortality. Rural population is about 100 million, urban population on the order of 63 million. So it makes sense that our numbers for a rural area is on the high end of that range. So so far the numbers look consistent with the World Bank data that I displayed earlier. How about a simple error analysis? Well, this is a proportion. And the classic formula there, of course, is to multiply that proportion by 1 minus that proportion, divide by the number of observations, and take the square root of that. And so that's what I did, very simply. And that number is 0.4. So I think what we can say is that, and that's 1 sigma, one standard error. So what we're saying is that in 353, in 2019, the 353 deaths correspond to a mortality of 6.8 plus or minus 0.4 per 1,000. Similarly, for 2020, it's 6.7 plus or minus 0.4. There's no difference. If you then calculate the excess mortality by just subtracting one from the other and dividing by this 6.8, of course, we have a single year, right? Where our denominator is 2019, not, for instance, 5 years, as I showed you for the US data before. But if you propagate those errors in the standard way, what you come up with is an excess mortality of minus 1% plus or minus 8%. And that's the number to compare with the plus 19% that I showed you for the US. Earlier in the talk. So we have a considerable uncertainty, and maybe we can do better. But it doesn't look like the mortality reached anything like the levels of the US or Western Europe. And the implications for that could be very significant. Now, what are the issues that we still need to think about? Well, there could be underreporting, right? You call a household. We certainly have evidence that reporting COVID, positive cases of COVID is suppressed. Newspaper reports and even some journal papers indicate a level of stigma. Families don't want to reveal that there's COVID. We can only partially address that. We think that mortality may be a different category. It may not be quite as sensitive to that, especially if it is obtained in with the repeated census, as I described to you. But that is something to think about. How about some form of selection? So we couldn't reach 28% of the households on all 3 occasions. But it turns out they're not very different in terms of the age distribution. They're not very different in terms of the level of education. The people we didn't reach were slightly less educated. And so that's, again, what Yuling Yao hopefully will help us address. When you look at the data as well, there's no large difference. I have some backup figures that I can show you later for people interested. In the timing of the deaths, the monthly deaths over these 2 years, the self-reported causes of death are not very different. There's no big upkick, for instance, in respiratory disease or dying from that. And there's no difference, importantly, there's no big difference in the age at death between these 2 years for this particular population. So that gives us some confidence. It is a rather unique data set probably, but there are these caveats to keep in mind. And what I'll wrap up with is a point that was made by Mushfiq Mubarak, an economist at Yale, and his team back in April, looking at when he was comparing North America and a number of developing countries, including Bangladesh. And his point at the time was that given the difference in age of the population and the impact of not being able to earn a living in Bangladesh being much more severe, even though it's bad enough in the US for many people, essentially he raised the question, does it make sense to impose harsh social distancing measures in a country like Bangladesh? What he didn't know at the time, I don't think he had a way of knowing that, is that in addition, it appears that the rural population of Bangladesh also has been infected, but has not died to the extent people have died in other countries. And the fact that the lockdown was imposed in a somewhat haphazard way in Bangladesh was, from that point of view, perhaps not such a bad thing. This is what I had to say. Thank you.
Thank you, Lex. I actually have a couple of questions, and if folks could raise their hands, I'll get to you in a moment. So just sort of jotting down the numbers and thinking about it, it seems that the biggest difference between Bangladesh and the US is the overall infection rate. Is that correct?
I don't think so. I think it's the mortality rate that is very different. So that earlier plot I showed, the infections, I think there wasn't that much testing. People had to pay 100 taka, a couple of dollars for testing. At one point, the testing went down after that. So at least the articles I've read, and it's not my specialty, is have focused on this difference in the mortality rather than the cases.
Okay. And can you comment on what exactly is the difference in age distribution for Bangladesh versus Western countries? And if one were to simply take the data from Western countries and somehow normalize for age distribution, would you all of a sudden have a much lower mortality rate?
Right. So that's certainly what Mushfiq Mubarak did. And so that's why he said, let's think twice about social distancing and mostly stopping all economic life. I haven't done that. We will do that with our data, of course. My understanding is that it has an effect, but it doesn't explain this enormous difference in mortality.
Okay. And there is a question posted in the Q&A, which I'll go ahead and read. It's from an anonymous attendee. Is there any data on the rate of intubation in the US versus Bangladesh, for example?
I wouldn't be the source of such data. I know there were shortages of various types, that some hospitals in Dhaka were overwhelmed. There was a shortage of oxygen. So I wouldn't be surprised if maybe the intubation at the beginning of the pandemic was lower than it was in other countries, but this is speculative.